One second, sir. First live show. So a warm good evening once again from IAP Trivandrum and to all the seniors and dignitaries in the platform. And this is the 15th episode of PG Club we are doing with the association with IAP Kerala. And we have an excellent academic session on all the previous episodes also. And we are looking forward to an excellent session today also. And we have a distinguished speaker, Thangavelu sir, with us also. So I welcome Dr. Kalpana Madam, the IAP President of Trivandrum, to deliver the welcome address. Kalpana Madam.
മാഡത്തിന്റെ പേര് കണ്ടായിരുന്നു. നെറ്റ്വർക്ക് എന്തെങ്കിലും ആണോ എന്തോ?
നെറ്റ്വർക്ക് ഇഷ്യൂ ആണെന്ന് തോന്നുന്നു. Madam, actually, Madam will rejoin us in later, I think. So I welcome Dr. Riaz for the address, the President of IAP Kerala.
Thank you, Dr. Srijit. So, respected guest speaker for the day, beloved Thangavelu sir, senior teachers in the platform, Purushothaman sir, Mohanda sir, and all my friends as well as students. So, we are actually reaching the fag end of the year. So, we are all happy that we could continue this Thursday PG Club without any break at all. And this year we were able to discuss we were able to discuss more than case discussions. We had OSCEs, we had a theory paper discussion, we have this invited guest lectures by the legends in the field. And for students, we were able to do a students congress, and also this Saturday we are having a physical session where the examination is going to be taught at Kollam. So all this is happening because only because of your enthusiasm, the students' enthusiasm. You are joining this platform without any break, and also this is available in the IAP YouTube platform. So as the exams are nearing, I wish all of you should revise your topics very well, and also I offer best wishes for the exams also. Back to Srijit to continue the program.
So, thank you, sir. Now I welcome Dr. Mohandas, sir, of the PG Club coordinator, for the address, and also to welcome the Dr. Thangavelu, sir, the speaker of today's program. Dr. Mohandas, sir.
Thank you, Dr. Srijit. Good evening, respected IAP State President Dr. Riaz, and today's speaker Thangavelu sir, and the senior faculty in pediatrics and their PG students. It is a great honor for me to be to organize this program for the last 2 years. And this year we had various types of programs, and our PG students, and more than PG students, the senior faculty are really enjoying this program. And hope PG students are viewing it in YouTube link, using the YouTube link also. And today, Trivandrum branch has organized the program. I would like to congratulate them for their effort taken. And today's speaker is Thangavelu sir. Sir needs no introduction actually. So he's a very well sought after speaker for various conferences. We have heard him several times, and we had very good moments to cherish, our lively sessions. And sir has his MBBS way back in 1968 and to 73, and DCH in 1982, MD in 89, and MRCP in 98. So initially he worked in various rural areas, hilly villages for 10 years. And then he became assistant professor in pediatrics in Madras Medical College. And he has served several years in the pediatric intensive care units. So he really likes to teach more and more in the PICU care. And after that, now he has served as Director of Pediatrics, Mehta Hospital. And he initiated the clinic for type 1 diabetes in ICH, Chennai, and where he could enroll more than 400 patients. So he was a PALS instructor, and he has contributed several chapters in textbooks. He has won so many awards, including Best Teacher Award, Best Doctor Award. He had done orations in various conferences, and he is the emeritus editor of IJPP. And beyond all this, he's a very good orator and a very, very gentle, calm, and very, as already mentioned, very good examiner also. I am inviting Thangavelu sir for today's program.
Thank you. Thank you very much for your profuse and nice introduction. I make myself deserve for that. Thank you, Riaz and Mohandas sir and Srijit. Shall I start presenting my PPT?
Yes, sir.
Please share, sir.
Sure. Okay, thank you for the opportunity given to me to have an interactive case scenarios in ER and PICU. These are the two places from ICH, Mehta, and for a few years in Kingdom of Saudi Arabia, I learned, because those days there is no traditional learning for pediatric intensive care. We have to learn on our mistakes. So you can imagine how many mistakes we would have done. Learning is not very easy at that time. I'd like to thank Dr. Riaz, Dr. Gopi Mohan, Dr. Mohan Das, Dr. Kalpana, Srijit, Karthik Gopal, and Dr. Priya Srinivasan, Sujit Kurian. Thank you very much for the opportunity given. And we are extremely friendly and thankful to Shija, very rare character to come and do the pediatric nursing training. And I think fourth and fifth decade, still every day I feel the unforgettable dear friend. She taught us more than what she learned from us. We always remember that. For the kind attention of PGs and the community pediatricians, see, learning is a slow process only. So don't think that because I'm asking questions to a student, don't think that I'm an upper platform, you're in a lower platform, nothing like that. Both on the same platform. Many a time I used to tell our PGs, I learned a lot of new things from our junior colleagues and postgraduates. I will never forget that. I will never hesitate to accept that. I did not know that, but you only taught me. At the same time, I'm also using a lot of pictures and videos. So I just offer my salutations and respects to the kids and their families for sharing their visuals for the sake of medical education despite their pain. So we are not in the habit of getting legal signature from our patients and parents. That is not our custom. Now only we have started doing it. So openly, I offer my salutations to them. In the next presentations, I have some 10 long case scenarios and about 8 to 9 short case scenarios, only 2 slides. So long case scenarios for the interest of postgraduates, and the shorter one, rapid fire, is for the interest of community pediatrician, because they are all very fast in disposing patients and they don't have much time. I'm just concentrating these 2 slides are rapid fire for the community pediatrician, longer one for the PGs. I'm just giving interpretation. Black text is just information. Questions are put in the red text. And blue text is the answers, so that you can see the slide and answer accordingly. We always follow the clinical pathway in ER and PICU as per the IAP, ALS, or PALS course. Any child coming to emergency room, we don't rush to make a diagnosis and start the treatment. First is assess the physiological status. Hardly within 1 to 2 minutes, initial impression, primary assessment, secondary assessment, tertiary assessment. So we go through the same process. When you repeatedly do it, we'll spend only 3 to 5 minutes. Stabilize the child first. Physiologic state is assessed by degree. For example, shock means compensator hypotensive shock. If it is type means hypovolemic, distributive, cardiogenic. Focus history, any diarrhea or vomiting or fever. Problem-oriented examination. Identify a crucial clinical sign. Look at around the bed. You get a lot of clues around the bed. Then you kickstart the diagnosis of physiological status based on etiology based and investigations to confirm them. The first case scenario, this is a 4-year-old boy, had 5 days fever, noisy breathing, and voice change. Developed right upper lobe pneumonia and treated as OP. We look at X-ray. Since morning of day 6, child developed altered level of consciousness and voice responsive and irritable. See, this is a case presented to me and the next day from the year PG. So you can look at the physiological status, voice responsive, so altered mental status, tachypnea, saturation is normal. And then, so child has got a physiological status of respiratory distress, hemodynamically stable, altered mental status, and the child also had a stridor. So she presented to me stridor and altered mental status. Generally, I will not ask the PGs to tell the diagnosis. I will try to make it. Half the time I will fail in my making diagnosis, half the time I will succeed. So I just want to have a trial. So this is a child with acute onset of altered mental status and stridor, previously treated for right upper lobe pneumonia. This is a shot. So generally, a child with a typical child of the group will present like this. Usually they will be fully conscious. That's why I did not mask the face also. This is a classical child of the group. So how do you see inspiration? Riaz, I think the audio is...
Yes, sir. Yes.
Okay.
Well heard, sir. Well heard.
Yeah. Okay. You hear a sound. Stridor is the inspiratory sound. Wheeze is a musical expiratory sound. Grunting is again an expiratory sound. So this is a moaning sound. Yes. Well, how do you decide looking at the video as inspiratory, expiratory? Whenever the sound occurs during retraction, means that it is a stridor. There is retractions. Look at again. Sound happens when there is retraction. So that means it's an inspiratory sound, harsh inspiratory. So how curiously she is looking around. She is fully conscious. That is a classical factor of truth. But here, this child is present with altered consciousness. I told my PD, it is hypoxia or hypercarbia. Immediately, this was a reverse what you see here now. I told her the answers, but she said no. Because saturation was 96% on arrival in ER. When we did the blood gases later, it was 36% PCOD. Both are normal, sir. So now I am stuck. At that time, I didn't know the third cause. After a few minutes, I realized that the third cause is what is third cause. So I just like to ask the PGs, any one of you, what do you think the third cause here? Any child altered mental status in group, normal oxygen saturation, normal PCO2. What is the third probable cause? You just attempt. No, like me, you also may pass or fail. Nothing wrong in it. Your status will not come down. Please unmute and answer. Nothing wrong. Wrong answer is better than silence. Everybody makes mistakes.
Sir, in the chat box, there are two answers.
Please help me.
Roshan is telling hypoglycemia. Shifa is telling hypoglycemia.
Okay, this child glucose was also normal. I didn't include that. Now I know the fourth cause. Hypoglycemia and all is hypocalcemia. Okay, but hypoglycemia can cause altered mental status. Hypoglycemia, but not hypocalcemia. But it is neurogenic stridor. So neurogenic stridor can occur following seizures, abductor palsy, brainstem involvement, as happens in hydrocephalus, or any underlying neurological condition rather than a direct airway issue. So neurological is an important cause. Probably hypoglycemia also comes under that category. So it's a neurogenic stridor. This child glucose was normal, which I have not mentioned. So we presume that this child has got a neurogenic stridor. And because of the abductor palsy, neurogenic stridor can be there. Secondary 10th nerve involvement. So our anatomical diagnosis is brainstem involvement. Do you know the underlying etiology? If possible, Riaz, they can be included in the, they can directly answer, no?
Yeah, direct answer is better. You can unmute
better.
and
They can
answer.
unmute and answer or include them in the panelist link.
Please switch on your videos. Alka?
So now we think there is an underlying etiology. What do you think the
Vocal cord
etiological diagnosis?
Roshni was telling some answer.
Please.
vocal cord paralysis.
Okay, possible. What is the underlying etiology for the vocal cord paralysis and acute onset? Usually we see after post-surgery, post-cardiac surgery, sometimes trauma, sometimes mediastinal mass. When the X-ray did not show any mediastinal mass, there is no history of trauma. So anatomical diagnosis, brainstem involvement. Let us see what could be the possible etiology. So when the child immediately, in any child like this, immediately stabilization. So child was shifted to ICU under controlled condition, intubated without any using muscle relaxants. There was bilateral abductor palsy was noticed, which is the reason for stridor. Okay. Now we'll go through the causes. Acquired causes are iatrogenic trauma, neurological disorders, damage to the vagus nerve nuclei, or ADAM. Chronic causes are degenerative disorder, malignancy, and congenital causes, including hydrocephalus, but that is not likely here because the child has been well. The duration is only 1 week. So we think about acute acquired causes. Trauma, there was not trauma. Neurological disorder, probably ADAM also may be possible, or some way damage to the vagal nerve or nuclei. So what do you want to do now? What investigation you want now? Now we have stabilized the child, intubated, and child is connected to the ventilator. You want to do one specific investigation which will identify the underlying etiology, because the management is going to be on the underlying etiology. Any guess what do you want to say? You can keep your video open, no problem. No, don't think there is an examination. You are in the PICU. You are in the PICU duty. So you will tell the, you will arrange, I think in real life you will make arrangements rather than answering.
Roshni, you can say that answer after unmuting.
MRI, sir. MRI.
Very good. Neuroimaging. You want prefer CT or MRI?
Sir, MRI.
I'll prefer CT because CT is available in every hospital. Quickly we can go and come. But MRI may take half an hour. Still you want to do CT? Don't think that all the seniors and teachers are always correct. I am wrong. Because CT will pick up only hemorrhage or any tumor. It cannot pick up everything.
Sir, MRI.
MRI is the right thing. And rather we are intubated and ventilating the child now. The child is quite stable to go to MRI and come. So you are correct, MRI only. So what do you expect in MRI? You told Adam only, no? I'll show the picture. So this is MRI. So here, fibrotic bronchoscopy and direct visualization during intubation identify vocal cord palsy. The first one is a normal MRI, coronal view. This is now MRI, usually T1, T2, flare image. T2 and flare only will show all the demyelination. So here, if you look at it, this is normal. This is brainstem, spinal cord. They are normal, almost same color. But here, look at this. Here, they got a hyperintensity of the brainstem. Hyperintensity of the pons and medulla. Hyperintensity means demyelination. So how do you say T2 MRI? CSF is T2 flare means CSF is black. Gray matter is white, white matter is gray. So this is a T2 flare. T2 flare showing hyperintensity of the brainstem. So this is a high brainstem demyelination. You can also see in the sagittal, it's a normal pons here, normal pons and medulla. Here you can see demyelination. So hyperintensity showing demyelination. So this diagnosis was made within about 6 to 8 hours. Child came in the morning around 4 a.m. Before, I think, at 2 p.m., we were able to come to a diagnosis. Here, main thing is you followed the routine rule, clinical history, examination, looking at a child, made a decision, ordered the right investigation, and we are able to prove the diagnosis. So noisy breathing, upper lobe pneumonia. What do you think upper lobe pneumonia due to?
Aspiration.
Very good. So when the time had aspiration, probably the it was not complete. So child remained conscious. When it increases, child developed edema and then developed altered consciousness. So within 8 hours diagnosis made, the child improved the IVAG, MPS and completely recovered. Now she's a 15-year-old girl, normal adolescent, thanks to the quick clinical problem solving. I thank all my team members, Dr. Sashidhar and Sandeep and Gauri Shankar. Courtesy, these are managed by few of our PG, Dr. Reena Ramesh and Annapurna Muthukumar, both of them now in Birmingham in NHS UK. They are former DNB PGs. So summary of the case, what the lesson we learned is when child presents the altered mental status, neurogenic stridor, Dr. Roshan, Roshni and Alka, remember I learned fourth cause from you, hypoglycemia. Nice, thank you. So in every class, not only the student learns, teacher also learns. So it's a neurogenic stridor. Then we thought acute in origin. So congenital malignancy is excluded, more likely Adam. Right upper level pneumonia explained by the aspiration. Stabilization. Before sending the child for MRA, MRA is not proving the diagnosis important. Child is stabilized. That is why, irrespective of the etiology, we intubate and stabilize the airway. How the clinical reasoning helped is history, examination, finally methodical approach, we reach a diagnosis. So that is the beauty of clinical reasoning, ordering the specific investigations. Thank you. So, okay, I just told this earlier. Detailed cases of postgraduates and rapid fire cases were the senior colleagues and community pediatricians. So, rapid fire, this is a well child, a school going child returned from school to her village home. The same night came to ER, ICH, middle of the night with difficulty in standing and walking. So, assess the child by pulse, airway is stable, stabilized with positive suctioning. Breathing, you can see the video, I'll show that a little later. Saturation is 90, low saturation, stable circulatory status, voice responsive child, see the face and the foot. What is the physiological status? So even senior colleagues also can answer for this one. Senior colleagues and community pediatrician also can answer. I just showed, look at the picture. I put arrows to identify the clinical. So I think it's very easy for you. You might have seen more than some 20, 30 cases.
Neurotoxic envenomation, sir.
Very good.
Ptosis,
Fantastic.
bite marks.
So can you describe the clinical sign here? Ptosis, drooping of the eyes and drooping of the jaw. Okay. Here, you are able to see the fang mark. So fang mark with cellulitis may be cobra. Fang mark without cellulitis may be crate. So probably crate bite. Look at the secondary to crate bite. And both bilateral ptosis and drooping of jaw resolved after ASV. No, very nice thing. So always go through the pulse algorithm. Airway, breathing, breathing, circulation, disability, and exposure. So without fang mark, you might diagnose this an acute Guillain-Barré syndrome, but very less likely for a Guillain-Barré syndrome to develop over a few hours. And so it is our duty to look for the search for the fang mark, do the investigation for hypokalemia before coming to a diagnosis of snake bite. So this is another child who is stridor. This is a 6-month-old child. Stridor initially looked like croup. But it was severe recurring intubation. Generally, croup children may not recover intubation. They may not be in such a severe status. So what is the quick? I have 3 questions for all 3 of you. What is the quick inference that comes from your mind? I am saying severe croup. Tell me some comment about a severe croup. How will you proceed further? What are the further differential diagnosis? I think you all 3 look like very brilliant students, so you can answer.
Epiglottitis.
Pardon?
Epiglottitis.
Very good. Epiglottitis is one possibility. But generally, epiglottitis, I'll just discuss. Riaz, you might allow some more time, 15-20 minutes more.
No problem, sir. No
I'm
problem.
going slowly. So epiglottitis, different, quickly I'll say difference. Epiglottitis, I just tell the character epiglottitis, more than 3 years, high-grade fever, soft stridor. So this is the classic toxic looking child. Here it's 6 months unlikely, no high-grade fever. Stridor will be very soft. You have to go close to the child and then observe whether the child has got any stridor. Here in the group, it will be harsh stridor. Third, you have to go, and the child will have a typical sniffing position. It is not there. So I don't think it is epiglottitis. Anything else?
So foreign
Okay.
body.
Foreign body, very good. Foreign body is more likely possibility. Only thing is 6 months is little more, only that toddler who move around and put a groundnut or button inside the mouth only. 6 months can happen, but less likely. Okay. How will we proceed further?
Sir, vascular
Vascularing. Okay, we'll come to that. Maybe you might reach a diagnosis, but tell me the step. How did you reach? So first ask the history, then examination. So we'll go methodically. So we'll see the further DD also. I think you come to a diagnosis, but still, severe stridor means only 2% of the hospital is group recovery intubation. So hence after stabilization, a detailed history examination investigation are needed. Because when a child recovering stridor because of severe croup recovering intubation means it more likely to be a non-croup rather than croup. So croup is less likely here. What are the further differential diagnosis? I'll move on to the next slide. You asked the history. Now the history is mother told that yes, sir, he had tried similar problem earlier. We were in Bangalore at that time. He was admitted there and he was treated. So this is a second episode of stridor. So either it is recurrent or chronic. It is in between not so maybe recurrent. It's not acute rather. So it is not acute. That is one very good point we got in the history. And mother also worried that he is not gaining weight. In a croup child, usually weight may be normal. There is no reason for the child to lose weight or not gaining weight, not seen in croup. So DD is acute is as who said Roshan or Roshini? Rohan or Roshini. Epiglottitis, foreign body, anaphylaxis also you should think, and laryngeal edema. These are all the possible. Quickly I will tell that with fever means epiglottitis, retropharyngeal abscess and croup. Epiglottitis high grade fever, retropharyngeal abscess high grade fever. In croup it is a low grade fever. A child with stridor, no fever means anaphylaxis causing laryngeal edema, hypocalcemia, foreign body. These are all the three neurogenic studies. These are the causes. Chronic recurrent means you have congenital abnormalities, subglottic stenosis, vascular ring, and mediastinal mass. Very nicely, he suggested could be a vascular ring. So these are all the possibilities we have in mind. Okay, now you are moving in the right direction. Tell me what investigation you want to do. Come. You're all brilliant than me. You know that what investigation you want. You need not waste time on opening your video. We keep your video open.
ECT to look for any mass.
Very good. Why do you want a plain CT or the contrast enhanced CT?
Contrast
Why?
vascular, if keeping
Correct.
in mind vascular ring.
Absolutely correct. So what happened to the child? Clinical examination, what will you see? History or history clinical examination? I didn't put that question. What do you want to do in clinical examination? Look for any hemangioma. The child has got hemangioma in the limb, and stridor means 50% of the time the clotting hemangioma is the cause for stridor. So look for any hemangioma. Look for large head causing hydrocephalus. These are all clinical clues for stridor. Large head hydrocephalus also can cause stridor. If the child has got hemangioma, probably there may be a glottic hemangioma. That is the reason for stridor. These are the clinical clues. The child was extubated on third day, but unfortunately, stridor recurred with desaturation. We have to re-intubate that child. But at the 12 hours, we identified one important clinical finding in the follow-up examination, which is called biphasic stridor. I will ask you all three. Stridor is the inspiratory or expiratory sound? Inspiratory. Then what do you mean by biphasic stridor? You have to explain me two terminologies here. Failure to thrive is there, and biphasic nature of the stridor. These are the two clues for each diagnosis.
Biphasic is at the level of vocal cords or below, can be biphasic.
Fantastic. Your answer is correct. Why do you want to so very slowly? Confidently, you say. You are giving a very right answer. Biphasic means both inspiratory and expiratory. That happens when the obstruction is between glottis and carina. That is called intrathoracic upper airway obstruction. Intrathoracic upper airway obstruction between glottis and carina. What is the clue from failure to thrive? What is the connection between stridor and failure to thrive?
It's
How many tubes?
congenital.
How many tubes are inside the chest? Long tubes, natural tubes.
Trachea, esophagus.
Trachea and esophagus. So failure to thrive means esophagus is also obstructed. So naturally feeding difficulty will be there. So we have two clues. So biphasic stridor, intrathoracic upper air obstruction. We have something which is blocking both trachea and esophagus. So don't think that MRI and CT, MRI all will bring the diagnosis. No. They are only to confirm what you made the clinical diagnosis. So your clinical diagnosis will narrow down to a acute stridor. It's a biphasic stridor means obstruction at the level of glottis to carina, and it is a problem which is affecting both trachea and esophagus. So with this amount of very good clinical strength, we move to the reasoning that we already explained to it. Stridor and failure remains that we have three DDs: subglottic stenosis, mediastinal mass, and vascular. All the three can cause. This is the classical, I told you, know, in upper extrathoracic upper air obstruction. This is intrathoracic upper air obstruction. Below the carina, above the carina and below the glottis. We got 3 DED. Subglottic stenosis will not block the esophagus. So child may not have failure 3, may have failure 3 because of the chronic respiratory issue, but failure 3 may not be a gross feature. Mediastinal mass can block both, but will be seen only in plain CT is enough. So you need CCT to prove the vascular ring. So we have 3 DDs, and if mediastinal mass, most of the time X-ray will also show. Our X-ray did not show anything. So more likely vascular ring. Now, what do you want to see in CCT? There are many vascular rings, but which is easily identifiable. I just showing this, the normal. So always, whenever you see an abnormality, go and compare with the normal. This is a trachea. This is a left descending aorta. So brachiocephalic vein. So aorta is only on one side, left side. But here, this is a left aortic arch and right aortic arch, both combined to form a circle to block the esophagus and trachea. So this is a child with double aortic arch. Vascular ring, double aortic arch. Congratulations to you. One of you suggested vascular ring earlier. So biphasic was a clue. Surgical resection was done. Child improved. See how nicely we are able to come to a diagnosis from history, examination, confirmed by investigation. This is interesting. I don't see interesting. It's a challenging child. The 2.5-year-old male child, second born child of non-consanguineous parents from Rajasthan. Presenting complaints are fever for 2 days, vomiting for 1 day, and then reddish brown urine for 1 day. And you can look at the child, the picture, and then come back to the pulse assessment. So what do you see here?
A severe pallor.
Pallor.
Yeah, larger, smaller foot, severe pallor, acute onset, sudden onset. It happen only in 2 situations. You keep the 2 possibilities in mind. We'll read the physiological status. The airway is stable. Because it's a big slide, I just highlighted important finding. There is tachypnea. Respiratory rate is 60. Okay, saturation is 84. Remember, child is in NRM. Heart rate is 160, pallor, febrile. 100 is not a big fever to cause tachypnea. So what is your physiological status? What is the physiological status of the child?
Respiratory failure.
Shock. Decompensated shock.
Yeah, look at the circulation status. Pulse is well felt. Hello? Hello? Sir, CML can அப்புறம் பேசுறேன் sir. So, here circulation status normal, no? Well felt, CFT less than 2 seconds, BP is 80 by 50. So it is not shock. Physiology status is effortless tachypnea. You see that. But I don't know whether it is effortless tachypnea or respiratory failure because saturation is
84.
84 in oxygen, with oxygen. Okay. What are the cause of acute onset of pallor? This is your answer before I move the slide.
Ongoing bleed.
Very good. Fantastic. Bleed may be obvious or occult. Okay, that is one cause. Second cause, Riaz will not give me more time. You have to answer fast. He might give 15 minutes or 20 minutes more. Quick. One is blood loss, hemorrhage.
Hemolysis.
Very good. Fantastic. Hemolysis. And do you have any clue here? Reddish brown urine. Okay. So acute obvious blood loss or acute intravascular hemolysis. Hemolysis will happen only in intravascular hemolysis. Now look at the color of the, what do you think? Comment about the color. This is the urine, point of a yellow arrow. So this is almost dark brownish blacks. So can you connect all the pictures and provide the few DDs? Pallor, what is this? Intravascular hemolysis, hemoglobinuria. Hemoglobinuria. See the color? No, it is not hematuria. Dark, black, brown. Okay, now I'll think over the highlighted text. Now you just tell me, why did I mention Rajasthan? Generally, Rajasthan doesn't give any clue. Effortless tachypnea doesn't give any clue. Saturation 84 despite NRM you are giving almost 10 to 15 liters. Oh, it is not corrected. Failure in the palm of the child that you explained. I think probably that we won't discuss again. It's because of hemoglobin, acute intestinal hemoglobinuria. Okay. Any question you want? I am the parent. What question you like to ask me?
Any recent history of diarrhea?
No diarrhea.
Any recent medication history? Medication?
I don't know, doctor. What medicine you want me to? You can only paracetamol.
Malaria endemic region.
Fantastic thought. Malaria. Because nowadays, south, we don't have much malaria, but north still they continue to have. So I agree. Maybe a severe malaria. Okay, very good. Good clue. Severe malaria, black water fever. Very good thing. Maybe it happens in other states also. Okay, that I keep it in mind. But this is not a child malaria. Because fever is only one. And there are some clues. There is no organomegaly, I think. No hepatosmegaly. No hepatosmegaly. That is very splenomegaly should be there. Mostly severe malaria should be there. But anyhow, that is one of the DDs. Here you see saturation 84. Okay, can I move on to the next slide? It may look very complicated, but go through slowly. You will agree with me. Here, I have taken ABG. Okay, I have taken ABG for this child. And ABG pH is, because it's a crowded ABG slide, I'm showing it separately. pH is 7.42 normal. Bicarbonate is 16.8. Red light. How come that when the saturation is low, but here the pH is 263? Something is wrong, no? Either my saturation is wrong, or my ABG is wrong, or something wrong with the patient. What do you think? Where is the mistake? ABG, saturation, or the patient? Quick.
Patient.
Patient, correct only. Okay, patient. So this is called saturation gap. See, what is the peripheral saturation or pulsar saturation? 84. Here the SaO2 is an arterial blood saturation, 99.9. Normally, difference between SpO2 means peripheral pulse oximeter, peripheral saturation or pulse oximeter saturation. Both should be almost equal or a maximum difference only 2 or 3. Here the difference is quite 15, almost 16. This is called saturation gap. So, okay, we'll keep that in there and come to the table. So the child oxygen was started NRM. NRM, after starting NRM also saturation did not improve. Then you told me, no, what drugs you asked me. I will also include the toxins. I will ask 2 questions to them. Is there any way, did he have any of this problem earlier, past history? In your family, anybody had this sort of passing a black colored urine and sudden pallor? Because in northern India, GCPD deficiency is common. Okay, and compared to South India. And what toxin can lead to intraocular hemolysis? Simple toxin. I don't know if it's available in Kerala also. This is called naphthalene balls.
Methemoglobin.
Yeah, naphthalene ball. Do you have naphthalene ball in your place?
Yes, sir.
Common. So,
Yes.
methemoglobinemia. Why do you say methemoglobinemia? Because because a child who does not improve saturation and doesn't have a severe respiratory problem, you think of methemoglobinemia only. So, correct, you are correct. But toxin, GCPD, autoimmune, these are the DD for intraocular hemolysis. Toxin, GCPD deficiency, autoimmune hemolytic anemia, malaria, microangiopathy because of TTP and HUS. So, I think before I put the question, you were given the answer. It's a single cause that can explain both intraocular hemolysis and methemoglobinemia. You are very nicely put it. Congratulations to all of you. So, single cause that can lead to intraocular hemolysis, methemoglobinemia is naphthalene ball, GCPD deficiency. So, naphthalene-induced intraocular hemolysis, hemoglobinuria, methemoglobinemia. You see, retic count is 2%, MP negative. LDH was high, GCPD levels are lower. And then teardrop cells, cystocytes, bite cells, helmet-shaped cells, microspheros, occasional blast. I thank my PG Dr. Sriharsha, DNB PG. This is methguin level is 7.6%. What is co-oximetry? Any idea? Before that, look at the picture. This is the tube of the normal blood, mother's blood. This is baby's blood. So this child has got a chocolate brown color, dark chocolate brown color. is methylhemoglobinemia. This should give a clue. See, every child gives some clue in different ways, but it's up to us to pick it up. So co-oximetry is a test. Can anyone of you tell what is co-oximetry? Co-oximetry is a test which will identify abnormal hemoglobins. So you will evaluate when the child has got abnormal hemoglobin. So what is the summary of the case and lessons learned is acute onset of pallor, blood loss or acute hemolysis, low saturation despite oxygen saturation, abnormal methylhemoglobinemia, urine hemoglobinuria favors intravascular hemolysis, causes we all discussed finally turned out to be GSPD deficiency causing intravascular hemolysis. So toxin like naphthalene is a reason for all these things. And co-oximetry confirms the presence of methylhemoglobinemia. Generally, methylhemoglobinemia will be more symptomatic if the meth levels more than 10%, but anything above 2 is abnormal. More than 10% is abnormal. But here it is only 6, probably because of severe anemia is also aggravated the hypoxia. So now we go back, all the possibilities we are seeing, pale, acute onset of pallor, low saturation, normal SaO2 and hemoglobinuria. So this child, what is the problem in the management, do you think? What is the management? Hello? So what is the management of methylhemoglobinemia? Hello? Hello?
Methylene blue.
Hey, very good. IV methylene blue. But IV methylene blue, before giving IV methylene blue, you should do an investigation. GCPD levels. If GCPD levels are lower, you can't IV. It's a contraindication for IV methylene blue. IV methylene blue itself will induce hemolysis. So here the GCPD levels are lower. So you cannot give IV methylene blue. So vitamin C is not useful in acquired acute methylhemoglobinemia. So I'm thankful to my PICU colleagues, Dr. Sasidharan, Sandeep, Muttaya, and Dr. Shobana. They did exchange transfusion for the child because the one thing which will correct anemia and methylhemoglobinemia is a exchange transfusion. So this child underwent exchange transfusion because child hemoglobin is very low too. We can't leave it like that. We have to give RBCs. At the same time, meth level has to be brought it down. So single intervention which you can do is exchange transfusion. I'm sincerely thankful to Dr. Sasidharan, Sandeep, and Muttaya, and Dr. Shobana for doing exchange transfusion. And child improved with it. And we avoided IV methylene blue, and child came around. In fact, when the child came to us, GSPD levels were not available. But because North Indian origin, Rajasthan, so we presumed the child may have GSPD deficiency. We avoided that and exchange transfusion helped the child. Child completely recovered within a week time and then sent home. So now, are you happy in reaching the diagnosis, PGs? Okay, this is a rapid fire. This is a child admitted in ICU with convulsions, bulging AF, pallor and posturing 2 days after first dose of DPT. So the admission diagnosis was DPT encephalopathy. So anything which is given free of cost, people will blame that. So DPT was given on Wednesday. Friday, the child developed convulsion, posturing, and bulging AF. DPT encountered diagnosis. A sincere PG identified a good clinical sign. One of our professor used a crack joke. This is a simple case of malaria. Even my PG will diagnose. He said only my PG will diagnose because postgraduate students are very curious, young brains. They think very fast. They are very sincere, curious to know. So one of our PG looked at the child and identified a good clinical sign. Are you able to pick it up? What is the clinical sign here? Quick.
The name of the clinical sign.
Yeah. What the clinical sign you clue identify? Just name the clinical sign. I'm not asking the
So
underlying etiology.
someone has written bruises.
Very good, fantastic. So classically,
Confusion.
any child with convulsion, make it a habit to any child with convulsion, bulging. Look for bruises and purpura. If bruises are there, you are reached the diagnosis. So unconscious child skin bruise means it's a clear evidence of intracranial bleed. So there is a skin bleed. Naturally, the cause of convulsion must be intracranial bleed. So what are the DDs and what are the investigations? Quickly. Okay. So bulging AF means meningitis.
So they have written battered baby syndrome.
Very good.
Meningococcemia.
Very good. Third.
Abuse.
And both are same, no? But so what is the correct name is non-accidental injury. Nowadays we don't call it battered child or abuse, no? Non-accidental injury. Accidental injury, a child was fell down from the cart, accidental injury. Non-accidental injury is it's an intentionally created injury. So bulging AF means meningitis or hydrocephalus. The child has got bulging AF and pallor means intracranial bleed. That's what our child had. Bulging AF plus pallor means jaundice means neuronal cholestasis. You see how nicely clinical clue gives a diagnosis. So we have been taught by our teachers because when I was doing house agency, imagine no ultrasound, no CT, no MRI, no echo, no echo. That's all. So think how no, our teachers are so strong in clinical medicine. They taught us all these things. So these three alone we can reach a diagnosis. So lab was done, and last is the DD for intracranial bleed is a bleeding. You told no accidental injury, non-accidental injury. Third one you didn't mention, which is bleeding disorder. So bleeding disorder spontaneously bleeding can occur, or even with a simple trauma they can develop, a trivial trauma they can develop. So PT was done, which PT showed prolonged more than 1 minute INR. Platelets were normal, hemoglobin is low. Look at a CT, plain CT showing a dense shadow. We used to, whenever we teach PGs, used to tell that CT reading, we must learn something because it is done in urgently in the night or emergency situations. CT, two things you think of. It is hyperdensity. Then more white shadow means all BCT, B complex tablet. We used to give B complex tablets when we were all young in from the hospitals. BCT, B for blood, C for contrast, T for tuber. If it is a hypodensity, remember AEI, abscess, edema, infarct. This AEI mnemonic was given by one of our student from Kerala called Nesri. So remember, hyperdensity means BCT, B complex tablet. B for blood, C for contrast, T for tuberous sclerosis. So the child managed with intubation, ventilation, PRBC and vitamin K, FFP. Child completely recovered. I thank the unknown. I didn't remember the name of the PGs from ICH. Thank them. So this is a child where you see a different picture. Can you look at the picture? Just I'll give you 30 seconds time. Look at the picture and you can make a diagnosis. So look at the picture. Okay, I'll show one by one. This is a bruises in the neck. What do you see here? Please.
Pallor.
Pallor.
Very good. What do you see here?
I
Bleeding.
see
Bleeding.
bleed.
Intracranial
Pale.
bleeding.
Pale stone.
Jaundice.
Jaundice.
What diagnosis?
Neonatal cholestasis.
Fantastic. So quickly, even without CT, we can say paler skin bleed. Even without CT, we can come to diagnosis cholestasis. That is the beauty of clinical medicine, clinical reasoning, clinical medicine. CT only confirm your diagnosis. Again, rapid fire. 3 months old baby. Baby cried in the night. Most of the advertisement nowadays says no. The baby cries, give grape water. That's what a grandmother followed that advertisement. She gave grape water, and then child developed stopped crying spells, but child developed grunting. The child was brought to ICGR when my friend Dr. P. Ramchandran was on duty. Around 2 a.m., child was brought with grunting. Look at the picture and make the diagnosis.
Grandmother gave something else, some poison.
What it is? What's that something else? See, whatever I'm presenting here is our teamwork. It's not only from me. That's why I'm just mentioning the names of our colleagues and PGs. Look at that. Normally, tongue and lip look like what color it will be? Pink.
Pinkish.
It's white necrotic.
Oral thrush.
Oral thrush is acute. Will not cause grunting.
Some poison.
Pardon?
Some poison. Grandmother may have mistakenly given something.
What
Corrosive.
poison can cause? White
Corrosive.
necrotic. Corrosive. Fantastic. Corrosive. Fantastic. See how everybody have the knowledge. Only thing we don't apply that, or we wait for the investigation to come to a diagnosis. You make a diagnosis, clinical diagnosis. Very fantastic. Corrosive is the correct diagnosis. Corrosive poisoning. What she gave is the corrosive, because this bathroom cleaning liquid was kept in that grape water bottle. She gave that. The corrosive poison. So the child, in fact, the child succumbed to this. Child had perforation of the stomach, esophagus. We couldn't save the child. So this is a spot diagnosis. Many a time we might even save the child, no, by doing gastrostomy or nil oral surgical intervention. All that will probably save the child. This is a little long story, so I may take more time for this. 10-year-old boy referred as status epilepticus. Even from nearby medical, they called us and said we had a child status epilepticus, intubated, ventilated, and we have extubated him on day 5. In day 6, we were asked him to do the incentive spirometry. Again, he developed convulsions and reintubated and sending to us. A child reintubated means possibly we were thinking of maybe meningoencephalitis with infarct or meningoencephalitis acute subdural effusion or acute rise of ICP. This is the first hospital case scenario. Second hospital, when he came to us, when he was transported in the ambulance, my PG observed that the boy was trying to communicate. He's showing thumbs up sign, all that, which is not possible in a meningoencephalitis. I'm okay signal, particularly when the sedation was weaned before changing sedation. So this looks very completely paradox. So we look for an alternate cause from what they thought, where history played a major role. You build up your answer, I will ask you. And then you will look at the X-ray. No, when the child is reintubated, no, you will be also not in a hurry to extubate him immediately. So we kept him in ventilator for another 24 hours. Only the way raising doubt, look at the X-ray. Here there's a bilateral opacity. All these within 24, 30 hours. Bilateral opacity, and then bilateral, the right side is more of hyperlucency. Right side is suspected emphysema, pneumothorax, put an ICT. So, looking at that, my PG said, sir, it doesn't look like neurologically, it looks more like a respiratory tissue. How does respiratory tissue can cause convulsion to that extent requiring intubation? What exactly happening? Any differential diagnosis? What do you think?
Foreign body, sir.
I completed. I don't accept only one word. You just go to the chain. But it is a foreign body. That's what you said, no?
Yes.
I agree with you. Just go through the sequences.
Mobile.
You are correct. You are correct. You are correct. You explain me the situation.
Mm.
You are correct. Go through that. Okay, I'll explain. I think you reached the correct point. Thinking about it, because why foreign body? Because varying this thing. So one side opacity and then becoming black and again becoming white. So parents' history, what at 8:30 a.m. when we ask the history after 24 hours only, we also sit and talk to the parent. Whenever now there is a conflict, anyway, conflict in the office, industry, among the laborers, among the politics, we sat for talks. When we sat for talks after 24 hours admission to ICU, asked the parents. 8:30 Monday morning, the school boy was ready with the uniform to go to school. Then he understood that the parents planned to go for a marriage after he is sent to school. Then he said, I will not go to school, I will come along with you. So he skipped the school and went to the marriage hall. That means he was a fully conscious, well child. So meningitis doesn't happen like that. Okay. From the first hospital, referral hospital, they said, we received the child around 11:30 a.m. He was in a tonic seizures, hypoxia, posturing or tonic hypoxia. So we gave LoRa 1, LoRa 2, midazolam, treated as status epilepticus, intubated, ventilated. We expect him on Thursday morning. Just like she showed multiple collapse because as one of her PG suspected, migrating foreign body can cause collapse as well as subset emphysema. When you use incentive spirometry, he worsened and developed a posturing, hypoxia, reintubated. So what is the missing link? What happened to him between 8:30 to 11:30 a.m.? What happened? So I asked the parents to talk to the playmates. So after 8:30, when they went to the marriage hall, this boy was happy to see all his friends and relatives are there. All the boys together were all running around, playing around the marriage hall, shouting and laughing. Playing, shouting and laughing. Simultaneously, he was eating groundnuts. The poor epiglottis got confused. So showers of groundnut pieces invaded the upper airway. And then he developed tonic spasm and went to the second hospital. You know the link is complete now. You go through that blue, red, and blue. It was really interesting to identify that. Then you understood that he was laughing and eating groundnut It went to the foreign body. So complete, maybe main upper airway tracheal obstruction leading to severe hypoxia, tonic seizures. It was mistaken as status epilepticus, intubated, ventilated. Once you intubate and ventilate, no, the foreign body will go to the periphery. Then after bronchoscopy, that Gauri Shankar did the bronchoscopy, he could identify multiple tracheobronchial foreign bodies. Or ENT surgeon Balakumar removed that nuts by rigid bronchoscopy, and child completely recovered thanks to Dr. Sachidaran, Vivek, and other PICO colleagues. The lesson learned here is allow some time for history, even in ICU. So history is not, without history, we could not have come to a conclusion at all. You understand how nicely they look like a Scotland Yard inquiry. This history gave us very good clue. So allow some time for history. Sit with the patient, take the history. Rapid fire. The child, when he was in Gulf, the child was referred to a 6 weeks old baby with multiple skin bleeding disorder. That was a diagnosis. That is a referral diagnosis. PD in the CBC was normal. PT-PTI are all complete. Now their investigation, everything was done. Everything was normal. Everything is normal in only one bleeding disorder because factor 13 deficiency. That was also not there. But you see the bruises. Anybody give the quick diagnosis that Riaz will give you 100 rupees. Riaz, you can also give more. Do you think?
Non-accidental injury.
Non-accident.
Only I can give only half mark. Explain how.
Bite marks.
Fantastic. Riaz, you can give them 50 rupees.
She is the president, vice president, sir. So we shall give.
Send the number. I will give you GPay number. Send the really. Just send me the GPay number. I will pay. See, very nice. No, fantastic. No. So very close to the clinic. Thank you, ma'am. Madam Vice President. Thank you very much.
Thank
See,
you,
see
sir.
the bite
Thank
mark.
you.
Beautiful bite mark. No, non-accidental injury. Okay, good. So this is the bite mark. So nothing. Now we know that mother on antidepressant. He wanted to bite the husband, but he could not do that. That's why he bit the child. Then we sorted it out. Okay, this is a child repeated vomiting and lesson learned. A 2-year-old child repeated vomiting for 2 weeks. No seizures, no LOC. I asked the history. Mother said earlier he walked at 15 months. Now he's 2 years old. He was running around without any difficulty. Now always clinging to me. She does not like to walk. That's the history given. Abdominal examination was normal. So used abdomen was done. LFT, RFT were normal. Can you tell me what are the cause of vomiting in broad groups? It will help us to reach a diagnosis. Broad group. No, I'm not telling the disease. Telling about system involved. What are the systems that can lead to vomiting?
GIT.
Very good. GI. Commonest then.
CNS.
Fantastic. CNS. Third, metabolic. Specific. Even a simple URA, LRA can cause vomiting in children. They have low threshold vomiting. In abdominal cause of vomiting, they allow either pain, diarrhea, bleeding. Nothing was there. CNS cause, what do you expect when you think of CNS cause? My Wi-Fi is unstable. If it is interrupted, please call me, Andreas.
Raised intracranial pressure.
What are the features? Convulsions,
Convulsions.
altered
Hypertension.
consciousness. Nothing is there in this child. Child is fully conscious, no seizures. So we thought it could not be a CNS. Oh, I just wanted to do a CNS examination. So I went like a warrior and went inside to do it. I like doing neurological examination. I went inside. But the baby was clinging to the mother and shouting. I could not even touch and feel the pulse. So I could not do any CNS examination. Is there any shortcut? I told you a shortcut for CNS examination. There is a shortcut, which our Professor Kumaresan taught us. When you can't examine neurological examination, because the child is not very cooperative, we would like to make the child walk and observe. The child may not walk when you are inside. So I just came out of the consultation room. I was waiting outside, told the father, let the child walk. But now when everybody is out, no, only father, mother was there. You just make a video. So you would like to look at the video. What do you expect in the video? You can just tell even before you look at the video. I just thank the parents for, because this will be very useful to prevent so many, diagnose so many serious conditions. What do you expect? Just for fun, I am asking. Okay, you look at What do you see here? The mother said she was talking very freely.
There is some balance issue is there.
Instability. Cerebellar,
Vestibular system,
some
vestibular.
cerebellar issues.
Ataxia, cerebellar ataxia. See, can you describe cerebellar ataxia? BGs. Broad-based. Unsteady stability.
Broad-based unsteady.
Classic cerebellar ataxia. Now you compare both. Cerebellar ataxia and broad-based. What investigation you want? I thank our Professor G. Kumaris in GK for giving me this point. Whenever you could not do a scene examination, just to at least make the child walk. Diagnose what do you want, what investigation you want. Okay, I'll come.
MRI brain.
What do you see? So, if child, MRI showed a big cerebral tumor. You are able to see this is again, this white eyeball means it's a T2 sequence. The child has got a cerebral tumor with hydrocephalus. So any child who is refusing to walk in a wheelchair, remember, true paralysis, pseudo paralysis, and unsteadiness. The child reflexes, even reflexes couldn't elicit. So it's not pseudo paralysis, true paralysis, it's unsteadiness. Unsteadiness means cerebral tumor. So how the clinical reasoning has helped us, even before you do the MRI, you come to diagnosis, probably cerebral etiology. Because you told the cerebral ataxia. Ataxia, Q2 and vomiting means cerebral tumor only. Okay. The child arrived in deep coma. This happened in 2008. At that time, we didn't have CT in our own hospitals in IC at that time. So history like that. When the family was shifting to a new house, this 9-year-old girl, previously well at 7 p.m., complained of neck pain. At 8 p.m., became drowsy and brought to the hospital at 9:30 p.m. See here. No, it's hardly 2.5 hours. The child is deteriorated. Well, child deteriorated very fast to decerebrate posturing, bradycardia, shock, shallow breathing, bradypnea, unresponsive, unequal, very sick child. See all that. What is the physiological status? Cardiac pulmonary failure, acute brain dysfunction, probably raised ICP because of the posturing. So here diagnosis is not important. So bag mask ventilation, intubate the child, RSA, intubate the child, normal saline bolus, connect to the monitor. After stabilization, we shift the child for CT scan. So definitely every pediatric ER will have at least one case like this in sudden onset of altered mental status cardiac failure, at least once a week. Hope you agree with me. If not once a week, once in 15 days.
Yes,
What are
sir.
the broad causes? Any idea?
Poisoning.
When the child
Actually,
comes to one minute, when child comes to a very sick stage, you have to do a lot of things. You have to talk to the parents, intubate, ventilate, everything. You may not have time to think. So you when you are awake, when you are at rest, you prepare the DD and keep it, which will be very, very useful for that. There are 6 DDs for this. Can you tell me? One is poisoning. What did you say? Please.
trauma,
Very good. Trauma. Very good.
infections, encephalitis, meningitis.
Okay, infection. Okay. Infection will not
Method.
come so sudden, no? 2 hours.
Okay.
Do you think 2 or 3 hours infection? Even where amoebic encephalitis will not come in 2 or 3 hours. Day second or third day only. So I don't agree with infection. So poisoning, okay, agree. Quick. Trauma also, I agree.
Bite.
Bites, very good. Envenomations. Okay, very good. I think you are all very good PGs trained by Shija and other professors. I don't know the other professor's name, that's why I'm not telling. So thanks to your teachers for training you very well. So just remember these 6 possibilities. Even for practitioners, it will be very, very useful. Whenever you see a child with altered mental status within 2-3 hours or within 6 hours, think of 6 possibilities. Unidentified injury. Nobody gives a child may not have witnessed injury. Unwitnessed seizures, envenomation, poisoning, cerebrovascular accident, mean thrombosis or hemorrhage. And metabolic issues, transient metabolic issue, hypoglycemia, hypocalcemia, or inborn metabolism. So I asked the mother, because when you're shifting the house, any cupboard would have hit the child. No. She was with me, child physically, no trauma. She didn't take any medicine, no snake bite, no scorpion bite. So she was stubbornly, she said, all are excluded. 2, 3, 4, not excluded. Only 5 can happen without mother's knowledge. 5 and 6 can happen without mother's knowledge because mother refused no poisoning, no envenomation, no seizures, no unidentified injury. So we thought of only 5 and 6. Do you agree with me? Only 5 and 6 are there. I could not see the fundus, but seen the fundus, probably I would identify retinal hemorrhages. I could not see the fundus at that time. And then metabolic issues like hypoglycemia, glucose calcium was normal, IEM work was not started at that time. So with that, we send the CT. CT, before sending the CT, child plus CT, we had this finding. What is the finding you see here? I'm just stressing the point that clinical examination, history taking, focus clinical examination will give you a lot of ideas. Investigation mainly to confirm. I don't say that investigation are not necessary. Investigations are first floor, second floor. Without ground floor, you can't build first and second floor. Without foundation, foundation and ground floor are the clinical examination, history examination. Your lab imaging all comes in second floor, third floor only. You can build, definitely you need second and third floor, but not without ground floor or foundation. So what is the quick clinical finding you see here? Quick, we're running short of time.
Right, paralysis. Hemiparalysis.
Okay, I'm a third year student. Explain me. How did he say paralysis? You didn't even touch a child. No, you saw the pictures. Your diagnosis is exactly correct. See, normally when a child is sleeping,
Foot is rotated.
lateral margin of the foot will not touch the bed. This is a gap here. Here it is touching the. When it's touching the bed here, means there are only two possibilities. One is fracture femur on the right side or a right hemiparesis. You are correct, absolutely correct. You are Roshni or Rohan or Alka. Who it is? Please, all any.
Vishnu Prasid.
Vishnu, very good, very good. Assistant professors. Fantastic,
There.
very good, sir, very good. So right hemiparesis is the diagnosis. Now we know the diagnosis. The child suddenly deteriorated. So it is not due to metabolic issues. Cervicovascular, which cervicovascular can cause sudden onset hemiplegia? Now we know the diagnosis. Pardon? Oh, that's all. Finished. Side? Didn't tell me sides. Left or right?
Left.
Left. Fantastic. So you made the diagnosis even before the CT. Now you look at the CT. Do you think CT made the diagnosis or a clinical examination?
Clinical examination.
Fantastic. Clinical examination for the diagnosis. You see I told you, BCT, blood, contrast, and tubers. It is called midline shift. So then the child underwent proved as MRI showed AV malformation rupturing. Then the child brought back of seats, went to the private hospital. And then after this surgery, the child came back because the neurosurgeon said that more than neurosurgeon, the person who resuscitated the child at the first hour is one who deserves appreciation. So you go and give him the sweet. The child, you see the scar, brought the sweet and gave it to us. So that is more important. Close clinical examination. I'll come back. I'll just repeat the same: unattended injury, unwitnessed seizures, envenomation, poisoning, cerebrovascular accident, and metabolic issues like transient metabolic issues like hypoglycemia, hypocalcemia, or IEM, inborn metabolism. Okay, I think we have finished it. This is a rapid fire. 2-year-old child referred as pneumonia. This came to our ER. One of our bright PG called Anjana was there on duty. And this is a child referred as pneumonia because child came with fever, grunting, respiratory distress. He's a child hydrocapillary plus VP shunt. They said, mother said they already had VP shunt also. Now he developed fever and respiratory distress, grunting. So he naturally think is pneumonia. X-ray was taken. What is the finding in the chest X-ray? What is the diagnosis? What is the treatment?
The shunt seems to be displaced.
Fantastic. Displaced VP shunt. Okay. Diagnosis? Yeah, this is a normal VP shunt. Very good. Very good clinical acumen. You see that, no? This is a normal VP shunt. This is the when migrate to a chest. So all the CS where will it drain? Not into the peritoneal cavity, into the
Pleural cavity.
Yeah, child has developed a pleural effusion full of CSF. Yeah, now you identify, now it is easier to treat. Tapping, removing the tube and reinserting the shunt. Okay, good. This is again a very puzzling case. Almost our team members struggled for a few hours to reach a diagnosis. This happened in the night. 14-year-old girl returned from school at 4 p.m. Single mother. When she returned around 9 p.m., the child was lying in the bed. It's a different child, but the child was lying like that in the bed. And then vomited a reddish color fluid. With that, she took the child to nearby nursing home. From there, they referred as reddish vomitus means it is portal hypertension, hematemesis. But hematemesis child will not have seizure or loss of consciousness. When the child was brought, child was in cardiopulmonary failure, bradypnea. So ABC was stabilized, intubated, and ventilated. So now we have stabilized the child. Now it's a time to think about the disability diagnosis. Here we have a child who has got altered mental state within 6 hours and having reddish vomitus. You see the gastric aspirate. Can you tell me the DDs?
Poisoning.
Poisoning. Very. Bites. No, you tell me the 6 things which I told. Scary 6. 2 slides earlier only we thought about. Unidentified injury, unwitnessed seizures, envenomation. This 6 will be very useful for you. I think we will definitely realize important. Envenomation, poison, cerebral accident, metabolic expansion, IEM. So, in the child was in the bed, just likely to be traumatic brain injury because the child is lying down on the ground or staircase or outside the house, maybe trauma. And then we are able to do the CT after intubating the child. CT brain normally excluded 2 things, cerebral accident as well as the traumatic brain injury. No fang mark, no features of scorpion. So usually scorpion envenomation or snake will not cause unconsciousness in the first initial few hours. So we have thought of unwitnessed seizures and poisoning. Unwitnessed seizures probably should have controlled with drugs and it should have subsided. So we thought strongly about poisoning, particularly unsupervised home environment, single parent poisoning is more likely. I'll put you 3 questions. What poisons you suspect? What toxin can cause respiratory refractory status epilepticus? What is the cause for reddish urine? So tell me 3, all 3 there, each one of you tell and manage one question. Okay. So toxins are seizures very strongly suspected poisoning divided into household substance or medicines. What are the household substances that can cause seizure? Camphor, Nemail, OPC, Gamaxin, insecticides, mosquito repellent. All this can cause seizures, which you can ask the history. Medicine means a simple glucose estimation will help us to narrow down into 3 groups. If there is hypoglycemia and seizure means oral hypoglycemia agent, beta blockers. In beta blockers, there will be bradycardia. OHA, there won't be any bradycardia. So bradycardia, hypoglycemia, seizure means beta blocker. Normal heart rate, hypoglycemia and seizure means it is oral hypoglycemic agents. If the glucose is high, isoniazid and theophylline can cause high glucose. Normal glucose means tricyclic antidepressant poisoning. Here, the child has got a sugar of 200, high anemia metabolic acidosis, SUVT is elevated, ECG is normal. So usually in TCA, we will have ventricular tachycardia. So hypoglycemia, bradycardia, and seizure means beta blocker. Only hypoglycemia and oral hypoglycemic agents. Hypoglycemia, ventricular tachycardia, and dilated pupil is tricyclic antidepressant poisoning. The child hyperglycemia, metabolic acidosis, high transaminases, both pointing towards what?
INH.
INH poisoning. So anything given in large numbers or end up in poisoning, you tell me now, you tell me, okay, I'll move on next slide. Then nurse came and told us, look at a urine sample. I consider as a child, urine sample and gastric acid, both are similar. Now diagnosis.
INH talks.
I can give only half mark. You didn't tell me the cause was red color. INH will not cause red color. So we took the serum and gastric aspirate to send to the TB research center. INH was present. INH caused convulsions. Reformation gave the color. Child confessed taking INH reformation about 30 tablets. I don't know. God only knows what reason made her to take that for a single parent's agony. What is the management? Quickly tell the management. We'll move to the next case.
IV pyridoxine.
Okay, very good. How much dose? Like in Kerala, Udupi, they give weight by weight. No, the child is born. 10 kg child means 10 kg, you can give onion or gold or currency depending on your economical status. So you have to give the doses here in INH poisoning, weight by weight, you have to give pyridoxine. So generally, to cause convulsion and encephalopathy, minimum 70 milligram per kg would have consumed. So we have to give 70 milligram per kg of pyridoxine. But unfortunately, IV pyridoxine not available now. Only IM pyridoxine available. So it is 400 milligram, 10 ml. We gave 800 milligram on both thighs. We are left out without any. Then we crush the pyridoxine tablet, give it through the NGT. Even that also works. Pardon? So IM pyridoxine, oral pyridoxine, child completely recovered within 36 hours. You could extubate that. Thanks to my team members, Dr. Anita, pediatric intensivist, and Dr. Sharada, pediatric emergency medicine specialist. So this is a child with isoniazid acid poisoning, came with hyperglycemia. Convulsion, triad of INH poisoning is hyperglycemia, high anemic metabolic acidosis, and convulsions. All three were present. So shrewdly, our team members sat down and within 6 hours reached a diagnosis. Treated with pyridoxine, child completely recovered. So that is the beauty of, we didn't do much investigation, no, except glucose and ABG. This is a rapid fire for senior. 18 months old child brought to the respiratory distress seizure without fever. Radiological clues for etiology. See, here I put a normal apparent humerus. So that gives a clue. So what is the radiological finding?
Hypocalcemia.
Very good. No, hypocalcemia will not be seen in the X-ray. No, you have to do blood calcium level. You tell me what you see.
Yes, sir.
Irregular metaphysis. No, irregular metaphysis, white physis, cupping, fraying, and metaphysis. And also you see the dilated anterior ends of the ribs. So all these features of
Vitamin D.
very good. So you see the normal humerus, no well-defined margins. Here it is irregular. Irregular metaphysis, white physis. So this is rickets. And ends. Okay, rickets. How does rickets cause? It can cause afebrile seizures. So you explained how the afebrile seizures occurred. What other findings? No, very obvious finding. No, this.
Harrison sulcus.
No, I'm not telling about the clinical finding. Here in the X-ray, what other findings do you have? Identified apparent humerus finding. Okay.
Cardiomegaly.
Very good. Cardiomegaly. So it's a cardiomegaly. Cardiomegaly is there. Pulmonary plethora is there. So it's a cardiac failure. So can you give one diagnosis for both? Seizures, vitamin D deficiency. So what investigation you want to do? I want to do X-ray wrist, serum calcium, serum vitamin D levels, alkaline phosphatase, phosphorus, and echo. Echo was showed features of low ejection fraction, and there was no anatomical abnormalities. Turned out to be, you see the X-ray wrist, classical cupping and fraying. Calcium, vitamin D level was less than 3, calcium 0.79 is normalized 1.2. So vitamin D deficiency, cardiomyopathy causing cardiac failure. Vitamin deficiency causes seizures. Both were well treated with vitamin D deficiency replacement. Completely child recovered. So the lesson we learned is any child coming with convulsion, generally as a pediatrician will take X-ray because aspiration pneumonia. Look at the upper end of the humerus. Upper end of the humerus will give you the diagnosis. Quick. We have spent almost 1.5 hours. Quick. So look at upper end of humerus. You will get a clue. Here we found out rickets. Okay. This is. I'll just without asking question. I'll go. The 5 months old child with septic shock, AKI, hypertension, child is on drug infusion, non-ventilated support, suddenly developed bradycardia. So what is the DD for bradycardia in a child on ventilated support? What is the confusing?
Block.
Pardon? No, what is the mnemonic for that?
Dog.
No.
Can you tell me each one? That is Sija would have taught.
Displacement obstruction.
Displacement, obstruction,
Pneumothorax.
Pneumothorax and
pneumothorax,
Equipment failure.
equipment failure. But here you see a paradox situation. You see bradycardia, whatever you told is for a respiratory etiology. Hypoxia child. Bradycardia and hypoxia means dope. Displacement, obstruction, pneumothorax, and equipment failure. But here, what is saturation here?
virus.
Normal.
What is it? 97.
97.
So this is not dope, something else. So when you see a child with bradycardia and low normal saturation, think of a cardiac cause. So I just want to be very rare. It's nice to see. And now secondary heart block. Finally, dropping on QRS. So this is the secondary heart block type 1 called Wenckebach phenomena. Now, okay, I told you diagnosis. Tell me what is the cause for this?
Hypokalemia.
Pardon?
Hypokalemia.
No, okay, potassium, I have not given you, potassium is normal. But the history tell you the diagnosis. You look at the history. Hypertension
Drug
on
infection.
what drug can lead to this? What drug will give you of hypertension? Same drug can it labetalol. Child was receiving labetalol. The secondary heart block type 1 is easy to treat. Remove the cause, it will be everything will be all right. Type 2, secondary heart block type 2 will always end up in pacemaker. So reason was labetalol. You stop the labetalol, child completely. 10-year-old girl with stridor, sore throat, and vague chest pain. Admitted in ITU for acute stress. Not really by initial medication. Look at the ECG and tell me quickly. For the sake of convenience, I mark by red arrow. Don't think that ECG, one of the ECG is cardiac. No, one of the ECG is pediatrician working in ER ICU. So we should know the basic ECG. Because why do you know? Why should we know? Because 24 hours ECG paper is running in the ECG is running in the monitor 24/7 in ER, PICO, NICO. So you can't say no. What is the red arrow says?
Prolonged.
Okay, very good,
Prolonged.
fantastic. What is the normal PR interval? And tell me what is the PR interval here?
0.26.
0.12 is normal. Here it is 6 small squares. 0.2 for definitely PR is prolonged. So we have a child with PR prolongation, an acute stridor. So what points you want to ask in one question? You can ask the mother about history. One examination. Tell me quickly. Quick. I'm the parent. What question you want to ask me? Hey, these are practically in and out. We are seeing this child nowadays. Not very rare.
Azithromycin. Azithromycin intake.
No,
Intake of
azithromycin. Child didn't take azithromycin. Correct. Azithromycin. Very good. Azithromycin is the right diagnosis thing. Azithromycin and prokinetic will cause this. Okay. Then next question. Okay, you are from a very
Vaccinations.
Vaccine status. The child did not take the second booster. You see the diphtheria patch. What precaution you will take? Wear mask and open them. Generally, we will pull down the mask and see the throat. So you have to wear mask and look at the throat because diphtheria, if you are not immunized, it will spread to you. So question you ask is vaccine status, examination, throat examination. This is a diphtheria with myocarditis causing posterior heart block. No, just clinical examination, simple ECG. 2-year-old child convulsion, altered mental status, afebrile, remained unconscious. Child had afebrile status too, it was a convulsion. Seizure got controlled, but child remained unconscious. Acute encephalopathy. Fundus examination, I attempted, I could not view the fundus examination. So what is the radiological finding? Any additional bedside test? Quickly. I heard that this was one of the questions in yesterday ASCII for DND students. Yesterday ASCII, one of our students told that they have this ASCII. Look at the X-ray. See, X-ray is a simple investigation. 500 rupees. 5 minutes you get a film. It needs only a good eye and good brain. That is bias. I told you, no, any child coming convulsions, look at upper humerus. Any clue in upper humerus? I'll indicate by what do you see here? I can tell the diagonal, but if you make the diagonal, you'll be happy. Okay, I'll tell you. Okay, I'll tell you the normal here. I knew that you got answer. It's a normal upper humerus. The normal upper humerus does not have this finding. What finding? This is the white band due to lead poisoning. Metaphyseal band, white deposit in the metaphysis. Look at anterior end of the humerus, anterior end of the ribs, all the anterior ribs that somebody has touched with the white pen. So deposit of lead here. Normally, in a normal X-ray, you don't see the medial margin of scapula may not be visible, but you can see the medial margin is well stained with a white pen. Look at carefully, the manubrium sternum is opacified. All this due to lead deposition, lead poisoning, radiology finding. Very simple. If you miss that, one or two occasions I have missed it. That is why it's still haunting my mind. Don't miss lead poisoning. Look at upper end of the humerus. Either you will find in an X-ray chest to the child with convulsion, 3 things you can identify. Can you tell me one by one? One is rickets, second is lead poisoning, third one? Recently, one of our PG from PG graduated working in Salem. Dr. Adisain, he found out the diagnosis.
Scurvy.
Just looking at the X-ray.
Scurvy.
Pardon?
Scurvy, sir. Scurvy.
Scurvy. Okay, scurvy will not cause convulsions. Scurvy will cause only painful limbs.
Yeah.
Skid. Absent-thymus. In any child with less than 2 years, absent-thymus will lead to skid and infection, seizure, or it may be a hypocalcemia. I just forgot the name of the syndrome. So, hypocalcemia, absent-thymus will lead to old age. Old age. I couldn't recollect the word. Dijard syndrome. So you can make a diagnosis. Hypocalcemia, absent-thymus in a child less than 2 years. So you can make three big diagnoses. They are not simple diagnoses. Rickets, lead poisoning, and Dijards. It's not a simple diagnosis. You can make by a simple X-ray. Only that you should train your eyes and brain to match it. Now you confirmed with the X-ray knee, lead poisoning. Lead lines appear as dense radiopaque bands. The metaphors are humorous. Lateral margin, medial margin of scapula. Sorry for the mistake. Anterior of the ribs, lead poisoning and encephalopathy. Okay. Coming to last two slides. This is a conversation between the resident and his professor at 11 p.m. A resident says, "Good evening, sir. This is a child with pneumonia and pericardial effusion. Chest X-ray and echo done, sir. What is wrong with this conveying the message to the professor? He is respectively saying, 'Good evening, sir.' What is wrong with it? PGs, you only have to tell. This is the way you tell your seniors or assistant professor senior. What will he see? Here is coming up to the diagnosis and investigation. There is no pulse approach. Pulse approach is A, B, C, D, E, airway, breathing, circulation, disability, exposure. The professor asks, "How is the child?" He says, "Lying in bed in ER, sir." "How is she?" "Has fever, sir." Still has not come. And finally, the professor says, "You are trained in pulse. Tell your assessment properly." Now he understood his mistake. He says, "Sir, please." He calls again at 5 minutes later. "Can you, one of you, airway maintainable, respirator 70, grunting is there." Grunting is a very important clue. Can you tell me what are the? Okay, sorry, I should not reveal the diagnosis. You look at. Can you hear the sound?
Yes, sir.
Yes. Okay, what is the sound? In Tamil, they call it as Mukki Mukki Moochu Vidrathu. Maybe in Malayalam, they may tell it different. What word they use for grunting in Malayalam?
Sir, say mukkun.
Very good. Mukki Mukki Moochu Vidrathu. Look at the eyes and tell me that. See, so there's a grunting is there. Grunting, there are three causes. What are the three causes of grunting? 3 or even 4 causes.
Pneumonia.
Very good. Pneumonia, parenchymal disease, pleural effusion or emphysema, cardiogenic shock, any abdominal pathology. Somebody said myocarditis, cardiogenic shock, and last abdominal pathology. Child with peritonitis also will grunt because it will restrict the splinter diaphragm. So just by grunt, no, immediately you got all the 4 diagnoses. So you look at the pain responsive child, you can look at the eyes, abdomen, muffled heart zone, CVS, muffled heart zones, hepatomegaly was there. Muffled heart zone, hepatomegaly, impaired consciousness, cardiopulmonary failure. I'm very happy to see how our ICH nurses in ER are functioning under the guidance of Dr. Indumati. You see, a child with acute encephalopathy, grunting and desaturation, what is the first drug for the child? Oxygen. Even in child shock, no? You see, how comfortably they given oxygen, then only are trying for IV access. If they try IV access without oxygen, that is wrong. See how nicely you learn from our nurses. Not our nurses, your nurses also. Learn from our nurses. See, they are doing wonderful job. See, acute encephalopathy, hypoxia, grunting. No, it is only oxygen. If my oxygen started, then I am trying for IV access. So, the X-ray showed cardiomegaly. But nowadays, focus has come, no? Point of care ultrasound. They are doing wonderful. Even youngsters in PGs are making diagnosis using the focus nowadays. We have accessibility to learn focus. But our days, it was in 2000. So I can see only cardiomegaly. This cardiomegaly has got some different quality. Can you tell one of you tell? It's a cardiomegaly. It's a child. It has got some different quality. Cardiomegaly, how will be the vessels in lung? Vascular markings. Yes, I come to the last few slides. Last few slides. Where the vascular mark, you saw the previous child with vitamin D deficiency cardiomyopathy, pulmonary plethora. Do you see pulmonary plethora here?
No, sir.
No. So if you see a child with cardiomegaly, loss of heart shape. Normally, heart shape is retained in cardiomegaly. You saw the previous cardiomegaly. Obtuse cardiophrenic angle. Here is normally acute. Absence of plethora means it's a pericardial effusion. You see, what is this? It is a pericardium. Tapping your pericardium. Okay. Nowadays, focus will identify. Maybe for one time, I'll just, without question, I'll just see this. What is the earliest sign of displaced tube? Probably desaturation, bradycardia, or ATCO2 will show a low PCO2. All that are investigation oriented. So bradycardia and cardiac arrest will happen after 5 minutes. So simple way is always every intubated child, if stand at the foot end of the child, look at the chest expansion. This I learned from one of our nurse called MR Saraswati. Stand at the foot end of the child and look for any good expansion. I'll show you the normal picture. I'm standing at the foot end of the child. And the synchrony is there. If the expansion is not good and there is asynchrony, definitely tube displacement may be more like I show you. Complete asynchrony. Look at this picture also. One hour or 1 hour. Please tell me. Few seconds, stand at the foot of the child, make it as a habit to look at the child, you can identify. All the other will come. This is the first one. ETCO2 will come in 15 seconds. 2 minute to volume, 15 to 30 seconds. Desaturation, 1 to 5 minutes. Bradycardia, 1 to 5 minutes. Cardiac arrest after 5 minutes. The clinical assessment is the fastest and simplest. It's a great power. This, I will just skip this slide for font of time. So I just finished my MBBS in 68, 73, 74. I did my house agency. I told you, no, beyond X-ray, nothing is there. No ultrasound, no CT, no MRI, no echo. Nothing is there. No ventilator, no pulse oximeter. Will you believe? So imagine this I got from one of the WhatsApp communications. This is the father. Father is the clinical examination, history and physical examination. On both sides, they got other observation, auscultation, inspection. So very happily roaming around in 1974, 50 years ago. Now it's 2025. The father has become very small. All his sons are grown up. His sons are ultrasound, echo, CT scan, MRI. So they are grown over the father. So the father is now stooping down and poorly walking along with his kids. Now the children are dominating. Children are modern technology. So everything is changed now in the last 5 decades. Children are overgrown, neglecting the father. Modern technology-based investigations killed our clinical reasoning. They are also needed. Clinical examination is primary. I told you, no, ground floor and first floor. Sorry, foundation and ground floor. Then you can build up by modern technology. So without clinical examination, if you completely believe modern technology, probably we'll be in soup. We will not make a diagnosis properly. So keep that in mind. Listen to the patient. He's telling the diagnosis. That's William Osler, his father of modern medicine. Clinical assessment is much faster than any monitor. No monitor can replace clinical skills of human brain. That is words of our friend and pediatric emergency physician, Indumati Sandhanam. So I request all pediatric pages should be trained in IAP ALS course within 3 months of joining the course. Hope you please follow that. I request the assistant professors, please ensure that your children are. I'm very sure that Shrija would be organizing PALS courses in IAP ALS courses in Trivandrum. Similarly, all professors in other medical colleges also. Let the PALS examination identify red flag signs, emergency situation, order for lab test. We need both clinical skills and technology, but clinical reasoning first. So what is needed now? He is Hippocrates. father of ancient medicine. He lived 2000 years ago. He said that the cause for jaundice is the liver. I don't know how he discovered. This father of modern medicine, William Hassel. He was responsible for all the rounds we make now, bedside teaching, rounds, and then journal club. And he brought in microscope to see the smear to make diagnosis. So great people. I think India also we have great teachers. I can quote some 5 teachers from our side. So every college, every institution will have some great teachers. So let us resuscitate the clinical skills. Who is dying for want of care? Youngsters should learn, practice, and apply clinical skills. Elders should teach them and impart the art of clinical skills. Clinical skill will direct the type of lab test needed and enrich the technology. Human touch is faster, stronger, and gentler than technology. So, my sincere thanks to Dr. Riaz, all the IT functionaries for giving this opportunity. Thank you very much. If there is any type of question, I am ready to answer. And I told you, I thank all the postgraduates, my colleagues, from whom we learned a lot. Thank you very much. Can I stop sharing?
Sir.
It is a great learning session, sir. Thank you, sir.
Thank you, sir.
So in the second case scenario, the vascular ring part.
Yes, sir.
One of the clinical signs which may be useful is on flexion. There will be exaggeration of the strider and radio-radial difference in the pulse. If it is the crossing of the subclavian, right subclavian, crossing to the right side in between the esophagus, and that is one of the rare reasons. It's not the.
Please repeat, sir. I just one is when you flex the neck, the pulse will become weaker, sir.
Yeah, radio-radial delay can be there because.
Okay, very good, sir. Thank you, sir. One more thing, sir.
Left subclavian crossing in between the trachea and esophagus to the right side is one of the reasons for this. It's
Okay, sir. Thank you, sir. So right subclavian arrives from the left side and crossing the midline.
Yes, sir. There can be a difference in the pulse volume between the two sides.
Fantastic, sir. I learned this from you, sir. Thank you, sir. Thank you, Purushottam, sir. Thank you.
So, and in the methemoglobinemia, that's an excellent case. We had a case in 90s, and at that time you showed the blood sample in the 2 test tubes. So we used the filter
color.
One drop from the control and 1 drop from the
blotting paper, sir. Correct, sir.
Light red and the other one is normal. That was one thing. At that time, we used methylene blue. At that time, it was not available. Lab reagent we autoclaved and used in 90s.
I could recollect the still same thing. The child who diagnosed around 5 p.m. throughout Chennai, none of the hospital had IV methylene blue. And we are afraid of using the normally available methylene for local application. Then we sent a person to CMC Vellore that Chelam Kribaran madam was kind enough to give us 4 vials. It's saying exactly same way only. Autoclaved sterile IV methylene blue she gave 2 rupees each for 4 into 2, 8 rupees only. Probably the travel would have spent more money on cigarette and tea. For IV methylene blue, I think autoclaved sterile IV methylene blue, it worked. And nowadays it's available in ampule, sir. Thank you. Thank you, sir.
It's available. Regarding that 5 causes you mentioned in the sudden deterioration, we had a case of the third ventricular tumor, colloid cyst, presenting like that.
Okay, sir. Third ventricular tumor. Okay.
Displacement causing sudden blocking.
ICP, sir. ICP causing. Okay.
Third
ventricular tumor. Okay.
Tumor also causing death of the boys.
The intracranial cause, probably like intracranial vascular event, it is a sudden IC price bicardical due to the third ventricular tumor. Oh, good, sir. I will also include that. In the next teaching, I will include these things.
Well, all the cases were excellent. It was a great learning session, as usual, sir. Thank you, sir.
Thank you, sir. Because they are not very unusual, rare causes. There are unusual causes, but it's still diagnosable. Because nobody knows, the police say, they used to say, no accused will, every accused will leave some clue for the police person to identify. Every disease will leave some clue in the history, examination, everything, sir. That's what I just want to pass it on to the younger generation.
Rija, you want to make any comments?
Sija, thank you, Sija.
You are muted,
You're
Srija.
muted.
Nothing, sir. Such a wonderful class. Reminded of all your classes.
We
All
used to
beautiful.
admire
Thank you so
Sija,
much.
even though she is a very senior person, come as a PG, she'll hold a bag. She'll write down everything in the wardrobes. She will talk to the parents and spend some 15-20 minutes to take the history. We used to admire. We used to tell that she's a role model PG. That's why I used to put 2 photographs, no? All the PGs, all generation, old people, professors, consultants, registrars, PGs, everyone will be very much attached to Sija. Thank you for sending a good message to youngsters.
Thank you.
Thank you, sir.
Thangavelu
Thank you
sir.
very much.
That's a very excellent academic feast, and only such an experienced teacher can discuss it in such a way. So, Parvati madam, any comment you want to?
Excellent academic
Thank you,
feast.
Bharati madam.
Excellent
Please.
talk as usual. Sir, I used to listen to your talks always. It's
Thanks, madam.
excellent.
Thank you, madam.
Okay, sir. Good night.
Thank you, sir. Thank you very much. Good night, sir. Good night, everybody. Thank you very much.
Thank you, sir. Thank you.
Bye. Thank you. Bye.
Good night.
Good night.
Bye, sir.